All right, everyone. Today we are diving into the skin, which I would argue is one of the most underappreciated organs in the human body. We tend to think of skin as just a covering, but from a pathophysiology perspective, it is doing some serious heavy lifting. It is a mechanical barrier, an immune organ, a thermoregulator, a sensory interface, a metabolic participant, and importantly for us as histotechnologists, it is a tissue where architecture matters tremendously. Small structural changes can signal inflammatory disease, autoimmune processes, infection, systemic illness, or even malignancy. And many of these begin at the microscopic level long before they become clinically dramatic. A fun perspective: your skin is technically your largest organ, averaging about 15 to 20% of total body weight. So when someone says organs are important, remember you are literally wearing one. Also, the skin is one of the few organs we can directly visualize before we ever put it on a slide. That makes clinico-pathologic correlation especially strong here. Today we're going to think like histotechnologists and focus on structure, disruption, and consequence. Because once again, the tissue tells the story. Let's briefly frame where we're headed so your brain has some organizational scaffolding. First, we'll review the structure and function of the skin because without normal pathology makes no sense. Then we'll talk about lesion terminology, and I promise not to turn this into a dermatology vocabulary marathon. But you do need enough familiarity to understand what clinicians are describing. Next, we'll look at environmental damage, especially sun exposure. Quick preview: dermatopathologists can often estimate lifetime UV exposure just by what the collagen looks like. Your skin keeps the receipts. We'll also discuss pigment disorders, hair abnormalities, inflammatory lesions, and of course, skin cancers. But I want you focusing less on memorizing condition names and more on asking what layer is involved, what cells are reacting, and is the architecture preserved or breaking down? Because that is exactly how you approach a specimen at the bench. One more important lens for today: the skin often reflects systemic disease. Sometimes the skin is the first clue that something deeper is wrong. So never underestimate a biopsy. It might be whispering something very big. Okay, this is our home base. If you lock this image into your brain, everything else today becomes easier. The skin has three primary layers, and each behaves very differently in disease. The first is epidermis. Think of this as your biologic armor. It is stratified, keratinized, and constantly renewing. And importantly, it is avascular, which means it depends entirely on the dermis for nutrient diffusion. Some worthless but memorable knowledge: your epidermis fully replaces itself roughly every 4 to 6 weeks. You are literally shedding your past, emotionally and histologically. Then there's the dermis. Now, this is where things get busy. The dermis contains blood vessels, nerves, glands, follicles, and connective tissue. When we see inflammatory infiltrates, vascular changes, or collagen disorders, this is often where the action is. Also, when dermatopathologists talk about depth, they are usually referencing invasion into this layer, because once something crosses the basement membrane, it has changed behavior. And lastly, the hypodermis. Primary adipose is used for cushioning, insulation, and energy storage, but also clinically relevant because deeper infections and aggressive tumors may extend here. From a grossing perspective, depth absolutely matters. Okay? Skin is one of those specimens where orientation is everything. If a biopsy is embedded poorly, you may lose the epidermis, which is basically like submitting a kidney biopsy without glomeruli. Technically possible, professionally heartbreaking. So proper embedding should allow you to visualize the epidermis, the dermal interface, underlying connective tissue, all in one clean plane of sectioning. When evaluating pathology, always ask, is this epidermal, dermal, both? How deep does it go? Depth often correlates with severity. Fun fact: we shed about 30 to 40,000 skin cells per minute. So if your house is dusty, congratulations, that is mostly you. Try not to think about it too long. As we move into disorders, keep this layered structure in mind, because nearly every skin disease can be better understood by asking one simple question: where is the disruption occurring? Once you know that, interpretation becomes much more intuitive. Before we talk about skin disease, we need to understand the real estate we're working with, because in dermatopathology, location is everything. We already talked about the skin being organized into three primary layers: the epidermis, dermis, and hypodermis. Think of it like a very well-built house. The epidermis is your security system, tough, protective, constantly renewing. The dermis is the infrastructure, so collagen, vessels, nerves, adnexal structures. And the hypodermis is insulation and shock absorption. Now let's translate that into what you care about as future histotechnologists. Again, the epidermis is keratinized stratified squamous epithelium, and yes, it is constantly turning over. The average epidermal cell makes its journey from the basal layer to the stratum corneum in about 28 days. Fun fact, again, your body sheds roughly 30 to 40,000 skin cells every minute. Histologically, pay attention to thickness variations, so the palms versus eyelids, integrity of the dermal epidermal junction, any presence of atypia, and disruption of maturation. Many skin diseases start here, so psoriasis, squamous dysplasia, melanoma, migration, so orientation before embedding matters more than students often realize. A poorly oriented shave biopsy can absolutely sabotage diagnostic interpretation. Then there's the dermis. If the epidermis is the protective shield, the dermis is the support beam. Two layers: papillary dermis, which is loose connective tissue, capillaries, and delicate collagen, and the reticular dermis, which is dense collagen bundles built for strength. When you see fibrosis, elastosis, or chronic inflammation, you are usually living in the dermis. Collagen makes up about 75 to 80% of the dermis, which is why aging skin loses elasticity. Collagen production declines and fibers fragment. So translation, gravity eventually wins. And then the hypodermis. Not technically part of the skin, but pathologists absolutely care about it. It's composed largely of adipose tissue. This layer anchors skin, stores energy, and cushions trauma. And importantly, certain tumors love to invade downward. When melanoma reaches the subcutaneous tissue, staging and prognosis shift dramatically. So again, depth matters. Always depth. When grossing skin, ask yourself, do I have epidermis? Can I see the dermal interface? Is the lesion centered? And am I demonstrating depth? Because the pathologist is asking one core question: where is this process happening? Once you answer that, half the diagnosis is already forming. Now we shift gears into the language of dermatology, because if you cannot describe what you see, you cannot communicate clinically. In dermatology, it's very descriptive. These are not random vocabulary words. They tell you how a disease behaves. So we have a macule. It's flat, color change only, no elevation. Freckles are classic examples. Histologically, sometimes subtle, maybe just melanin deposition without architectural disruption. Think pigment, not proliferation. Then we have a papule. Now we have elevation, but small, less than about 0.5 centimeters, often caused by cellular proliferation, local inflammation, dermal edema, and eczema is frequently presents this way. When embedding papular lesions, getting a full cross-section is key so the pathologist can evaluate both epidermal and dermal contributions. Then there's plaque. A plaque that decided to commit to a gym membership and bulk up. Oh, I'm sorry, it's a papule that decided to commit to a gym membership and bulk up. Flat topped, elevated, but broader. Psoriasis is the poster child, with epidermal hyperplasia, elongated reach ridges, and parakeratosis. Once you've seen psoriasis under the scope, you rarely never forget it. It practically announces itself. Scale, this is flakes of stratum corneum. This tells you keratinization is off schedule. Either cells are maturing too quickly or not correctly. Always think about turnover rate when you see scale. Then there's a nodule, deeper, larger, often dermal based. This should immediately trigger one thought: how deep does this go? because nodular lesions can represent benign growth or something far more aggressive. Grossing tip: never undersample a nodule. Dermatopathologists get cranky when depth is missing, and I say that with love. Big picture, notice something? Every lesion description is telling you where the pathology likely lives. Surface, epidermis, raised, epidermal or superficial dermal, deep, dermal or cutaneous, subcutaneous. Dermatology is basically geographic pathology. Now let's add fluid into the equation, because once the skin starts forming blisters or pus-filled structures, mechanism becomes extremely important. A vesicle is a small blister filled with clear fluid, usually forms from separation within or just below the epidermis. It's seen in viral infections like herpes. Histology often shows ballooning, degeneration of keratinocytes, a great example of how cellular injury translates into visible structure. Then there's a bulla, same idea, just bigger, greater than 0.5 centimeters. Burns commonly produce bullae because thermal injury disrupts epidermal cohesion. The level of blister formation helps differentiate diseases. So if it's intraepidermal, it's more fragile. If it's subepidermal, it's more tense. Again, location matters. Are you sensing the theme of today's lecture yet? Then there's a pustule. This is a vesicle that invited neutrophils to the party. Now it's filled with pus. Think infection, think inflammation. Acne is a classic example. Follicular occlusion followed by bacterial proliferation and immune response. For histotex, inflamed tissue can be softer and trickier to section, so gentle handling matters. A wheal. This is a transient edema in the dermis. It's often allergic. These come and go quickly, sometimes before a biopsy is even possible, which is frustrating diagnostically, but fascinating physiologically. Histamine increases vascular permeability and fluid leaks, which creates localized swelling. Your immune system is dramatic. Instead of memorizing these, ask, is this flat or elevated, fluid-filled or solid, superficial or deep, inflammatory or proliferative? If you are already thinking like a diagnostician when you do that. Skin biopsies are often tiny, margins are tight, orientation is critical, and dermatopathology is incredibly architecture-driven. A few microns can separate benign versus malignant, superficial versus invasive, and reactive versus neoplastic. So no exaggeration. Skin is one of the few specimen types where embedding skill directly impacts diagnostic accuracy. You matter enormously here. A worthless knowledge to end on: the skin is the body's largest organ, averaging about 20 square feet in adults. So technically, you are walking around in a very sophisticated protective suit at all times. Treat it kindly, wear sunscreen. The future you will be grateful. Let's talk about something preventable. Smoking accelerates skin aging dramatically, and the mechanism is actually very histology friendly. Smoking causes vasoconstriction, reduced oxygen delivery, impaired collagen synthesis, and increased matrix breakdown. The result? You get thinner dermis, decreased elasticity, and delayed wound healing. Some worthless but memorable knowledge: this is an actual clinical term called smoker's face. Prominent wrinkles, gray tone, and sagging. Nicotine is basically an anti-collagen campaign manager. Also, smoking increases the risk for squamous cell carcinoma. So yes, your DermPath colleagues care deeply about this history. Smoking is bad, UV radiation is its equally destructive cousin. Two main players: UVB, the sunburn culprit, and its direct DNA damage, think mutation risk. And then there's UVA, penetrates deeper, photoaging champion, and breaks down collagen and elastin. So hello, wrinkles. Histologic change you should associate immediately is solar elastosis, those thick, tangled elastic fibers in the dermis. Once you've seen it, you never unsee it. Also remember, repeated injury equals mutation accumulation, which equals skin cancer risk, which is why dermatologists basically want everyone bathing in sunscreen. SPF is cheaper than chemotherapy. Just saying. And finally, a slide that students never forget. Yes, these are real sunburn patterns. They happen when sunscreen is applied unevenly or not at all. Funny? A little. Educational? Absolutely. Because this slide reinforces something critical. UV damage is dose dependent and distribution dependent. Cells that are protected survive. Cells that are not accumulate mutations. Also, a quick histotech pearl. Severely sunburned skin may show apoptotic keratinocytes, epidermal necrosis, and inflammatory infiltrates, sometimes dramatic ones. So behind the humor is real tissue injury. When approaching skin, always think in layers. Where is the process occurring? Is it cellular, structural, or fluid driven? Epidermal or dermal? Superficial or deep? Because once again, the slide tells the story, if you know how to read it. Now we're moving into skin abscesses, and this is where inflammation becomes very visible, very tangible, and sometimes very uncomfortable. At its core, an abscess is a localized collection of pus caused by infection. Most often we're talking about bacterial infections, so Staphylococcus aureus being the classic troublemaker. But the key concept is this: the body is attempting to wall off infection. Think of it like the immune system building a biological containment zone. Inside that zone, you'll find neutrophils, necrotic cellular debris, bacteria, protein-rich fluid. From a histology perspective, abscesses are beautiful examples of acute inflammation in action, even if clinically they are anything but beautiful. Let's briefly connect the conditions shown here. We have furuncles or boils. These originate in the hair follicles. Infection tracks downward into the dermis and sometimes the subcutaneous tissue. Then there's carbuncles, basically a cluster of furuncles that have merged. Infection teamwork, but not the kind we like. Cystic acne, it's much deeper inflammatory involvement than your standard teenage acne. These lesions can cause significant dermal destruction and later fibrosis. Then we have hidradenitis suppurativa. This is a chronic inflammatory disorder affecting apocrine gland bearing areas, so the axilla, the groin. Recurrent abscess formation can lead to sinus tracts and scarring. And there's pilonidal cysts. This is often near the sacrococcygeal region. Hair plus friction plus inflammation equals infection risk. Abscesses present some technical considerations in the lab. Pus-filled cavities can collapse during processing, create sectioning artifacts, and distort surrounding architecture. Proper fixation is critical, otherwise everything turns into what I lovingly call histologic soup. Also, sampling matters because surrounding tissue may reveal granulation tissue, chronic inflammation, fibrosis, or even foreign body reaction. Sometimes the diagnostic story is actually around the abscess rather than inside it. A fun but mildly gross fact: before antibiotics, surgeons were taught a phrase you will still hear today: where there is pus, evacuate it. Simple, effective, and memorable. Now let's shift gears from infection to pigment, specifically melanin, the molecule doing far more work than most people realize. Melanin is produced by melanocytes in the basal layer and transferred to keratinocytes. So even though melanocytes make it, keratinocytes end up storing much of it. Most pigment disorders are not about melanocyte number alone. They often involve melanin production or distribution. Hyperpigmentation. This occurs when melanin production increases or accumulates. Examples include sun exposure, post-inflammatory change, and hormonal influences, and also certain metabolic disorders. Histologically, you might see increased melanin within basal keratinocytes, dermal melanophages, sometimes normal melanocyte numbers, meaning more pigment, not necessarily more cells. Then there's hypopigmentation. Now we move to decreased melanin. Two classic conditions to understand conceptually is vitiligo. It's an autoimmune destruction of melanocytes, so sharply demarcated, depigmented areas. And then albinism is a genetic defect in melanin production. Melanocytes are present but cannot synthesize pigment effectively. This distinction matters. It's presence versus function. Histology loves distinctions like that. Pigment evaluation sometimes requires special stains. So Fontana-Mason, which highlights melanin, helps distinguish melanin from other pigments like hemosiderin. Also remember, formalin pigment can occasionally confuse beginners, but thankfully we know how to manage that artifact. Worthless knowledge moment, melanin is actually an excellent natural UV absorber, basically your body's built-in sunscreen. SPF Evolution Edition. Hair is one of the best examples of the body operating on a biological rhythm. Not all follicles are synchronized, which is why you don't shed all your hair at once. And for that, we are all grateful. There are three major phases. Anagen, or the growth phase. This is the active phase. Cells in the hair bulb are rapidly dividing, pushing the hair shaft upward. Duration can be years, especially on the scalp. Fun fact, about 85 to 90% of your scalp hairs are in anagen right now. Histologically, follicles appear deep and metabolically active. Catagen, which is the transition phase. This is short but important. The follicle begins involution, essentially shrinking and disconnecting from its blood supply. Think controlled regression. Then telogen. This is the resting phase. The follicle is quiet. Eventually, the club hair is shed and the cycle restarts. Normally, this is staggered, but when large numbers enter telogen simultaneously, then you have telogen effluvium. Common triggers include physiologic stress, illness, hormonal shifts, or surgery. Students often find this reassuring. Hair loss does not always equal permanent damage. When evaluating scalp biopsies, pathologists often assess anagen to telogen ratio, follicle density, inflammatory patterns. The orientation becomes extremely important. If follicles are sectioned improperly, interpretation becomes, well, creative, and we do not love creativity in diagnostics. A mildly interesting fact, hair is made of hard keratin, the same structural protein found in nails, just organized differently. So technically, your haircut is a keratin management strategy. Now that we understand the normal hair cycle, let's talk about what happens when that cell gets disrupted. One of the most fascinating and honestly immunologically dramatic conditions is alopecia areata. This is an autoimmune disorder where the body essentially decides that hair follicles are suspicious characters and launches an attack. Normally, hair follicles exist in what we call an immune privileged site, meaning the immune system usually leaves them alone. But in alopecia areata, that privilege collapses. T cells surround the follicle and interrupt hair production. The follicle itself is not permanently destroyed. It's more like it gets bullied into shutting down. This is why regrowth is sometimes possible. What does this look like clinically? Well, sudden, patchy hair loss, smooth, round, bald areas, usually no scarring. That last point is important. Non-scarring alopecia means the follicle is still there. And if the follicle is still there, recovery is possible. Histology insight, the classic description, is a swarm of bees appearance. That refers to lymphocytes clustering around the hair bulb. When you see that pattern, your diagnostic radar should start lighting up. From a technical standpoint, scalp biopsies require excellent orientation. Follicular depth matters. Tangential sectioning equals interpretive chaos. We want clean, longitudinal views whenever possible. Fun fact, hair follicles are among the fastest dividing structures in the body, second only to things like bone marrow and GI epithelium. So when the immune system interferes, the effect shows up quickly. Now let's shift from hair loss to hair excess, because the body loves balance and pathology often shows us what happens when that balance tips. Hirsutism refers to excessive terminal hair growth in androgen-sensitive areas, particularly in individuals assigned female at birth. We're talking about areas like chin, upper lip, chest, and abdomen, essentially male pattern distribution. What drives this? Most often is an elevated androgens or increased follicular sensitivity to normal androgen levels. Common underlying contributors include polycystic ovary disease, which is very common, adrenal disorders, certain medications, and endocrine imbalance. Sometimes the follicles themselves just respond more aggressively. Think of them as hormonally enthusiastic. Microscopically, the follicle isn't abnormal in structure, it's responding to hormonal signaling. You may see larger terminal follicles, increased hair shaft diameter, and conversion of fine vellus hairs into thicker terminal hairs. So again, structure responding to physiology. Pathology often isn't about broken tissue, it's about altered signaling. Everyone has roughly the same number of hair follicles. The difference is what type of hair they produce. So the follicles are there, they're just making different executive decisions. If you remember one phrase here, let it be this: actinic keratosis is precancerous. These lesions result from chronic UV exposure leading to DNA damage in keratinocytes. Clinically, you have rough, scaly, sun-exposed areas, often easier felt than seen. Histology shows dysplasia of basal keratinocytes, hyperkeratosis, parakeratosis, and solar elastosis in the dermis. Translation: the skin has been aging aggressively under UV radiation. Why we care? A subset progresses to squamous cell carcinoma, so dermatologists treat these areas early and often. Superficial shave biopsies are common. Embedding must ensure the epidermis is perfectly oriented. Otherwise, goodbye diagnostic surface. Orientation matters more than students think. There are three major players you must know. Basal cell carcinoma, also referred to as BCC. This is the most common. It rarely metastasizes, and it's locally invasive. Histology classic, it has peripheral palisading nuclei. So it looks like the cells are politely lining up. Then there's squamous cell carcinoma, or SCC. This is more aggressive than BCC. It often arises from actinic keratosis. Histologic features include keratin pearls, intercellular bridges. If you see swirling pink keratin, think squamous cell carcinoma. Then there's melanoma, the one we respect the most, because melanoma is dangerous. It metastasizes early. Key concept here is that depth matters more than diameter. So the Bruce law thickness, store that in your brain. Histology may show atypical melanocytes, pegatoid spread, lack of maturation. Clinical takeaway is early detection saves lives. If you remember nothing else about melanoma screening, remember the alphabet. A is for asymmetry. One half does not equal the other. B is border. Irregular edges raise concern. C, color. Multiple colors is a warning sign. D, diameter. Greater than 6 millimeters is suspicious, but smaller lesions can still be melanoma. E, evolving. The most important feature. Change equals danger until proven otherwise. A clinical reasoning tip: patients often notice evolution before physicians do. Always listen carefully to that history. Histotech moment: melanoma specimens should never be poorly oriented. Again, depth measurement depends on it, so no pressure. Let's close this section with something extremely relevant to your future workflow. There are three major biopsy types. The shave biopsy, which removes superficial lesions. It's great for skin tags, seborrheic keratosis, some BCCs, but it's not ideal if melanoma is suspected. Why? Well, you cannot measure depth accurately. Then there's punch biopsy. It provides a full thickness cylindrical sample. It's excellent for inflammatory diseases, rashes, and autoimmune processes. It's often the dermatologist's diagnostic workhorse. And then excisional biopsies. The entire lesion is removed with margins. This is the gold standard for suspected melanoma because, again, depth determines staging. Skin specimens love to curl, so flatten gently before processing and always verify margins when indicated. Poor embedding can literally distort a cancer diagnosis. No big deal, right? Let's talk bacteria, because as much as we love a pristine H&E, the reality is that skin is constantly negotiating with microorganisms, and sometimes bacteria wins. The key concept here is barrier breakdown. Once the epidermis is compromised, even microscopically, bacteria can invade and trigger an inflammatory cascade. From a histology perspective, most bacterial skin infections are dominated by acute inflammation, meaning neutrophils, edema, tissue destruction, and sometimes abscess formation. Basically, it becomes a microscopic battlefield. Let's connect a few you see here. So cellulitis. This is a deep dermal and subcutaneous infection. Histologically, you'll see diffuse neutrophilic infiltration rather than a nice organized pocket. Think of it as inflammation that forgot how to respect boundaries. Then there's folliculitis, infection centered on the hair follicle. Under the scope, you'll see neutrophils infiltrating the follicular epithelium, sometimes rupturing the follicle. And remember, ruptured follicle equals keratin plus bacteria spilling into the dermis. Dermis does not appreciate that, so cue inflammation. Then there's boils, such as furuncles and carbuncles, right? So now we're talking abscesses, localized collections of pus. Histology buzzword, liquefactive necrosis. You remember that? Which, as you remember, turns tissue into the microscopic equivalent of soup. And then there's paronychia, this infection around the nail fold. It's often from minor trauma. Fun histotech reminder, nails are modified keratin structures, and keratin is fantastic at trapping pathogens. Then there's impetigo, so classic superficial infection, often showing subcorneal pustules filled with neutrophils. If you ever see a slide that looks like the epidermis is hoarding neutrophils, impetigo should pop into your differential memory bank. Whenever you see heavy neutrophilic infiltration in skin, ask yourself, is it diffuse or localized? Is it follicle-centered? Is it epidermal or dermal? Again, pattern recognition is your diagnostic superpower. And remember, bacteria don't need an engraved invitation, just a tiny break in the skin. Now let's shift gears from bacteria to viruses, the ultimate intracellular freeloaders. Unlike bacteria, viruses must enter host cells to replicate, which means the histologic damage we see is often due to cytopathic effects. Translation: the virus turns the cell into a factory. The cell loses control. The cell dies. Not a great career trajectory for the keratinocyte. We have varicella zoster virus, or VZV. This causes chickenpox initially, then can reactivate later as shingles. Histologic hallmarks is multinucleated giant cells, nuclear molding, and margination of chromatin. If those sound familiar, good. Your brain should automatically think herpes family virus because they all love that dramatic nuclear appearance. Shingles is especially interesting because it follows dermatomes, reminding us that this is not just a skin disease, it's a nervous system story too. Histology meets neuroanatomy, everyone wins. Then there's the herpes simplex virus, or HSV. These vesicles form because infected keratinocytes undergo ballooning degeneration, which is exactly what it sounds like. Cells swell until they basically can't cope anymore. Think microscopic water balloons. Then there's the human papilloma virus, or HPV. This causes warts. Histologic buzzword you must know is koilocytes. These are squamous cells with perinuclear clearing, racinoid nuclei. Yes, Raisinnoid is absolutely a real pathology descriptor, and I refuse to stop loving it. HPV stimulates epithelial proliferation, which is why warts are essentially controlled overgrowths of squamous epithelium. Then there's measles, not a primary skin infection, but manifests with a rash due to immune response and vascular involvement. Another reminder, not all rashes originate in the skin itself. A Histotech takeaway here is that when evaluating viral infections, look for cell morphology changes, nuclear abnormalities, and inclusion bodies. Viruses leave fingerprints. You just have to train your eye to see them. And yes, fungi. These organisms that remind us daily that moisture is the enemy. Fungi love warm, dark, and damp environments, which explains approximately 80% of human life. We have dermatophytes, which is athlete's feet and ringworm. Despite the name, ringworm is not a worm. Students are betrayed by this annually. These fungi digest keratin, meaning they stay confined to the stratum corneum, the hair, and the nails, rarely deeper unless the host is immunocompromised. Histology often shows hyphae within keratin layers. Usually a PAS or a GMS stain makes these pop beautifully and deeply satisfy the Histotech soul. Jock itch is Tinea curatus. Same organisms, different zip code. Again, moisture plus friction equals fungal paradise. Then we have candidiasis, which oral thrush or diaper rash. Candida is actually normal flora, but give it to the right opportunity and it becomes aggressively unneighborly. Histologic clues are budding yeast and pseudohyphae. And unlike dermatophytes, Candida can invade deeper tissues, especially in immunocompromised patients. Histotech pro tip, whenever fungal infection is suspected, never rely solely on H&E. Order the special stains because spotting faint hyphae on H&E is basically the histology version of Where's Waldo. Technically possible, unnecessarily stressful. Big picture takeaway, compare the 3 infection types. So you have bacterial, which will be neutrophils and pus. You have viral, which is going to be nuclear changes and cytopathic effects. And then fungal, you should see hyphae or yeast forms. Okay? Pattern recognition, again, always. Let's talk about when the immune system becomes a little dramatic. Skin hypersensitivity reactions fall under the umbrella of dermatitis, which simply means inflammation of the skin. But the why behind the inflammation matters. Broadly, we divide these into atopic dermatitis or eczema. This is a type 1 hypersensitivity reaction, meaning it is IgE mediated and often associated with allergies, asthma, and hay fever. Histologically, you will commonly see spongiosis, which is intracellular edema within the epidermis. Think of keratinocytes slowly floating apart like awkward middle school dancers. Lymphocytic infiltration and possible eosinophils in allergic cases. Chronic lesions showing acanthosis and hyperkeratosis. Barrier dysfunction is key here. The skin is not protecting the body the way it should. Remember, when the barrier fails, inflammation moves in. Then there's contact dermatitis. There's 2 major flavors of this. We have allergic contact dermatitis, which is a type 4 delayed hypersensitivity. It's T-cell mediated and shows up 24 to 72 hours later. Common triggers of this is nickel, poison ivy, fragrances, and latex. Histology again shows spongiosis, but often with more pronounced inflammatory infiltrates. Then there's irritant contact dermatitis. Not immune mediated, just direct chemical damage. Examples are harsh soaps, industrial chemicals, and excessive hand sanitizer. Histotechnologist Pearl, if the clinical history mentions itching, rash, and allergen exposure, start thinking spongiotic dermatitis before you even hit high power. Your microscope should never be surprised. The skin is not just a protective wrapper, it is often the first billboard advertising internal disease. When something is wrong inside the body, the skin frequently says, "Excuse me, you may want to look deeper." There are things such as systemic lupus erythematosus, or SLE. Classic findings here would be a malar or butterfly rash, triggered or worsened by sunlight, because lupus patients just cannot catch a break. Histology often reveals interface dermatitis, basal cell degeneration, immune complex deposition along the dermal epidermal junction. On immunofluorescence, you may see the famous lupus band, and yes, that is absolutely testable knowledge. Then there's diabetes. So poor vascular perfusion plus neuropathy equals impaired wound healing. So interdiabetic ulcers, chronic infections, increased candidiasis. From a tissue standpoint, think ischemia, necrosis, inflammation, and delayed repair. Basically, the wound healing process hits traffic during rush hour in Los Angeles. And then there's gout, caused by uric acid crystal deposition. While we think of gout as a joint disease, remember, it's an inflammatory process near the skin that can produce visible redness and swelling. Under polarized light, we'll see needle-sharp crystals with negative birefringence. Microscope flex moment. And then pregnancy. Hormones are running the show here. Common skin findings would be stretch marks, spider angiomas, varicosities, and worsening eczema. Mechanism equals connective tissue stretching plus vascular changes. The skin adapts remarkably well, but not invisibly. Clinical reminder, when you see unusual skin findings, always ask, is this primary skin disease or a systemic clue? Good diagnosticians think beyond the epidermis. All right, time for a quick histology nerd meets trivia night moment. Yes, historically, books were bound in human skin. The practice is called anthropodermic bibliopegy. I mean, both fascinating and deeply unsettling, right? Most examples date back to the 17th to 19th centuries and were often associated with medical or criminal records. Modern testing using peptide mass fingerprinting has confirmed that some of these bindings are indeed human. So if you ever wondered whether histology intersects with rare book collections, surprise, it does. No, this will not be on your exam, but yes, you will remember it forever. You're welcome. And that brings us to the end of our journey through the integumentary system, a structure that is far more complex than people give it credit for. Remember, the skin is not just a covering, it is an immune organ, a sensory organ, a metabolic participant, and a diagnostic window. And for us, a tissue full of patterns waiting to be recognized. If you take one major idea from this lecture, let it be this: pattern recognition plus mechanism equals diagnostic confidence. Never memorize slides, understand them, because once you understand disease processes, every tissue starts telling you a story.